My name is Lila Pennington. I am a board-certified family and gerontologic nurse practitioner. I have 2 certifications. I have been practicing in the state of Missouri as a nurse practitioner since 1977. I practiced for 19 and a half years in public health, where I did clinics that physicians hardly ever, if ever, came to. I did both baby clinics, I did family planning clinics, women's health clinics, prenatal clinics, and STD clinics. So I had that experience. Then I also taught for 20 years, or 21 years, at the MU Sinclair School of Nursing, where I, for the last several of those years, coordinated the family nurse practitioner area of study. So I'm very familiar with the education that advanced practice nurses have to go through. I just want to hit a few highlights. I have submitted written testimony, which goes into more detail, but I have some highlights that I want to know, because I know your time is short, and I want to be respectful of that. I know you'll be presented with more information on this, but there is a severe primary care provider shortage in Missouri, especially in rural counties. The current restrictions that we have, having to be within a 75-mile radius of the physician we collaborate with, and numerous others, inhibit our ability to actually go and help answer those access problems in those counties that currently don't have primary care. There's been some question about, do nurse practitioners go into rural counties? And there is a study from Johns Hopkins School of Public Health and Economics that looked at 9 states while they had a collaborative practice agreement, and then looked at the same 9 states after the collaborative practice agreement requirement was removed. Their percentage of nurse practitioners that went to rural areas increased substantially. So we are willing to go into underserved areas, and all of my clinical practice has been in underserved populations. So actually, I've been here before the law and since the law requiring a collaborative practice agreement has been in place. We had access issues when the law was passed. Since that time, the access to primary care in Missouri has decreased. It hasn't gotten better, it's gotten worse. And part of that is because of the requirement of the collaborative practice agreement, which inhibits APRNs from doing what they can do. Health outcomes. Currently, we rank, depending on the study, which source you look at, we rank anywhere from 42nd to 43rd in general health outcomes as a state. That means there aren't that many states that rank below us. And if you look at that list, all the states that rank below us are restrictive, like Missouri. All the 26 states that do not require collaborative practice all have better health outcomes than in Missouri. There are 40 years, there's over 40, about 50 years of research on nurse practitioners and other APRNs and the quality of care that they give. And they have found, in fact, you were asking about research, I have a 8-page annotated bibliography, and that's only a few of the studies. Some of those studies are, okay. So anyway, we have, yes, so we can improve, and we can improve the Medicare access to Medicare and Medicaid beneficiaries. We can decrease hospitalizations and rehospitalization. That's according to a study that I participated in. As far as cost, the Missouri Foundation for Health indicates that fully utilizing APRNs, such as NPs, would result in substantial health care savings of $1.6 billion over 10 years. So we're not talking, more study that has been done on that. I think one thing that rarely gets mentioned is that physicians receive pay for collaborating. Most physicians receive extra pay for collaborating with nurse practitioners, and that increases the cost of health care. Finally, I'd like to address our education. We are not educated as physicians. We are educated at the highest level of nursing practice, advanced practice nursing. We are nurses. Do we do some of the same things physicians do? Yes, but that has been the way throughout history. At one time, only nurses provided, the nurses were the first people to provide anesthesia, so that's not unusual. APRNs have to be a registered nurse first, so they have to have their RN education from which from day one, they're in clinical, do clinicals from day one. And on top of that RN education, then we add the APRN education on top of that. And so by the time that the APRN comes into her educational program, she's got years of experience as a nursing student and as a registered nurse. So medical students are not required to have any experience prior to coming into medical school. They don't have to have any healthcare experience. They may have, some do, but they are not required to. Our 6 to 8 years of education, depending on whether we're master's or doctorally prepared, compares favorably with optometrists, pharmacists, dentists, and lawyers. And all of those practice without a collaborative practice agreement with a different profession. You mentioned paralegals and lawyers. Paralegals don't have nearly the education of an advanced practice nurse. An advanced practice nurse's years of education actually get closer to lawyers. And if you want to look at a better comparison, look at optometrists who do a lot of the things that the ophthalmologist does, but they practice separately. They are not required to have a collaborative practice agreement with an ophthalmologist. They will, if a patient needs, in fact, your eye doctor may have been an optometrist all your life, unless you had an eye disease or required surgery, and that requires an ophthalmologist. We're a separate profession from physicians. We are not the same as physicians. You mentioned controlled substances. The information, currently we can prescribe controlled substances, but the amount that we can prescribe and what we can prescribe is limited, and it has to be written into the collaborative practice agreement, and if the physician doesn't want to write it in there, then we can't. Now, I heard what some of the data you had, but if you look at the National Practitioner Database, which looks at complaints against physicians, nurses, nurse practitioners, PAs, a wide variety of healthcare professions. Complaints against nurses are minimal on narcotics. Probably, and most of the studies actually show that we prescribe fewer narcotics, probably because as nurses, we have been taught many ways to relieve a patient's pain without using medication. So I just, that was one question that came up I wanted to answer. We do not want to practice as physicians. There are many things we don't do or don't plan to do that a physician does. We won't be practicing surgery. We specialize the minute we get into our APRN program. And so I can't go beyond the scope. I have to stay within the population of family. And that's a primary care specialty. Yes. So I have more information. If you mind asking questions, I'm done.
Questions? Representative Seitz.
Thank you. To inquire?
Go ahead.
Thank you. Changing the mileage piece and residency requirement seems like a no-brainer because we're doing that with other occupations such as policing so that we can get qualified people into those areas and they may not actually live there with, say, in a 75-mile radius. Do you think Missourians would be better served if we change the mileage requirement like this bill is trying to do?
I don't think this bill would remove any mileage because it would remove mandated collaborative practice agreements. I don't think it would help because some physicians don't want to be 75 miles away from somebody that they supervise. If they don't want to be 75 miles away, they aren't going to want to be 200 miles away. So I don't see how that's going to change things in a rural area.
Okay, thank you.
Representative Keithley,
To inquire.
go ahead.
Thank you. I have I guess I'm interested in exploring how these contracts work. It sounds like you've been involved with collaborative practice for a while. I'm assuming that then you're familiar with the contractual requirements, obligations, how these work.
Yes.
And some of the things, I guess I'll probably have some follow-ups too with it, but I guess just a place to start with it is how are these contracts formed in? Does a nurse practitioner approach a physician? Is it the other way around? And how is payment received? Is it a per patient? Is it a per work done by the doctor? And what do these contracts look like generally?
That depends on where the nurse practitioner is working. If the nurse practitioner is working within a system of clinics that a hospital owns, the hospital will negotiate the collaborative practice agreements. They'll find the physicians to practice with the collaborative practice nurses, and they will pay them substantially, an substantial amount to collaborate with nurse practitioners or advanced practice nurses. I know in the past, I've heard from some APRNs who owned their own clinics, and their collaborator might charge them up to $30,000 to $40,000 a year just to sign that collaborative practice agreement, so they could operate a clinic in an underserved area.
So is that's like a flat fee that gets paid out? It's not rated per patient. Do they take into account what the practice is like?
I think
volume, anything like that. How much work? I assume in collaboration that
depends.
It's different with every physician.
Yeah, that's going to depend on every physician. The collaborative practices I've been in the health department, most of the physicians, because we saw patients who couldn't pay, and most of the physicians did not charge much, if anything, for that. But then they didn't do much of anything either. The public health has an exemption in the collaborative practice agreement, and the physicians don't have to review as many charts. They don't have to be present at the clinic at any time. So their responsibility is a great deal less. And as a nurse practitioner at a public health clinic, I was very independent, except I could only prescribe certain medications depending on my collaborative practice agreement. I have been taught, and I taught my students how to prescribe medication appropriately. I taught the advanced pharmacology class at MU for several years, and in the advanced assessment class, I taught them how to do differential diagnosis and what to do with that differential diagnosis. So APRNs learn to do diagnosis and learn to prescribe. But in Missouri, we can't do that without a collaborative practice agreement, whereas as in those 26 other states, they can prescribe medications and provide treatments that were within their scope of practice without a written collaborative practice agreement.
So how does this change that collaboration? So in your practice, for example, how you do it, what would this, if this bill were passed as is right now?
This meant that in my, I'm semi-retired right now, and the job I currently have is doing Medicare home assessments, which does not require collaborative practice agreement because I'm not prescribing, and I'm not diagnosing new diagnoses. However, in my public health clinic, I saw a lot of patients who did not have a primary care physician or primary care nurse practitioner even. They had no one except the clinic there. And I caught, in my women's health clinic, I caught people with diabetes, with high blood pressure, and with numerous other health problems that had there been no requirement had this bill been passed, we could have expanded our hours in the public health department, and I could have provided care for those patients. Whereas what I had to do was I had to refer them to another clinic several miles away and hope that they went.
So why what was the point of that referral? Is that to get within a 75-mile radius?
No, it was because in public health there was an exemption. The public health exemption requires only certain things be done in the clinic, so I couldn't do primary care. I could do women's health, which is a type of primary care. I could do birth control. I could do breast and cervical cancer screening. I could prescribe certain limited medications, but it had to be a public health considered service, a population-based service. And primary care is not considered a population-based service. Therefore, I couldn't do that because my collaborating physician could not meet all the requirements of the collaborative practice agreement because, he didn't have the time. And so public health I could have done so much more for my patients in public health had I not had a collaborative practice agreement.
Okay. Thank you.
Questions? Representative Thomas.
I'm sorry, but I'm really confused. I thought you were saying just a few moments ago that it wasn't the collaborative practice arrangement that limited you, but it was being in the health department that limited you. That you said if you hadn't been in the public health system, you could have done so much more, which has nothing to do with the collaborative practice arrangement. So please educate me.
Yeah. The difference is that the collaborative practice arrangement was much simpler in public health. Therefore, it limited what I could do in public health. I also practiced in a federally qualified health center, doing primary care there, seeing anything that came in the door from a baby, 4-week-old baby, to a 90-year-old woman. I diagnosed everything from ehrlichiosis to pneumonia to the common cold. There, I had a more extensive collaborative practice agreement, but the physician was on that. In that clinic, there was a physician on site. In many clinics, there can't be a physician on site. That's a problem.
And I'd like to follow up, since you're actually someone who was in the field and working, back to the issue of malpractice coverage. Because in a collaborative practice arrangement, you're not the person where the buck stops. It goes to your collaborator. So I have a hard time understanding how, if there was no collaborative practice arrangement anymore and the buck did stop at your desk, that your malpractice wouldn't suddenly jump dramatically because you suddenly become the deep pocket. There's no one to pass that off to. And there are limits, the 1 million, 3 million, for example, that most people cover at this point. Would your insurance jump to cover those rates?
No, I pay insurance as a family nurse practitioner. It doesn't matter where I'm practicing. Now, I can answer that question because at a previous hearing on a similar bill, I was asked, was malpractice insurance higher in the states, the 26 states that allowed full practice authority? No, it is not. I actually applied to my own Missouri malpractice insurance company for a spot in the District of Columbia, which has a very high population of urban underserved population, as well as that's where all, of course, the senators and the representatives are. The District of Columbia is one of the full practice areas. It's 26 states plus the District of Columbia. My malpractice insurance in the District of Columbia, where I could have practiced without a collaborative practice agreement, was actually have been less, about $500 a year less than it was in Missouri. So, and the other thing is, lawyers will sue whoever has contact with the patient. So not only will the physician get sued with a collaborative practice agreement, but I will be sued and anybody else that had contact with that patient. I don't have a problem. I've not seen the malpractice rates go up in the states that have full practice authority. It just hasn't.
Well, as was mentioned earlier, Missouri is cherry-picked as very, very friendly to defendants and for big jury awards. So it's very difficult to compare Missouri to another state because that's, again...
That may be, but surely out of 26 states and the District of Columbia, there'd be one other state that was as litigious as Missouri. And the malpractice rates are not changed by state.
I'm
not
curious. Okay, and I'll take you at your word. I have some questions about that. But back then also to education. In no way are nurse practitioners comparable to physicians. I mean, there's no residency. I mean, you have hundreds of hours of training, but there's thousands, up to 10 and 20,000 hours of training for physicians. Again, the statistics I see are that upwards of 60% of nurse practitioner programs are either fully or significantly online. That's not hands-on, and the
Okay.
practicum work is not necessarily with people that are part of the program. They're not necessarily medical educators. There's not a standard of care there. So could you possibly address any of that?
Yes, I can, because there is a standard of care. Nursing schools are accredited by there are two different accrediting organizations for schools of nursing. And school nursing, an APRN program is accredited by one of those two. They have standards. They have who can be preceptors, who cannot be preceptors, and how often you need to meet with a preceptor. We would develop preceptor manuals for our preceptors. You know, a lot of physician training is not necessarily done in the medical school where they are. I know medical students who have gone off to train with a physician. The physician I practiced with in my fairly qualified health center used to have medical students come in and follow him around and get part of their clinical experience there. He wasn't on faculty anywhere. In fact, sometimes he would send them with me to see patients. So, you know, but you're trying to compare apples and oranges. We're addressing advanced practice nurses. And so, yes, we have to keep contact with our preceptors. As a coordinator of a family nurse practitioner program, have we chosen to eliminate certain preceptors? We have. If we found that the preceptor was not doing what was appropriate or not giving appropriate care, and we did monitor that, then we no longer would send students to that preceptor. Most of our, and then when you're talking about all these thousands of hours, there's a couple of things there. Again, RN education has a lot of clinical hours. Plus, most nurse practitioners have practiced as an RN. The person caring for you, if you're critical in an ICU, is an RN. There's not a physician standing over her shoulder all the time. You're under her care. That person is decide to become a nurse practitioner, then she needs more clinical hours, but she's already got hours and hours of clinical. And sometimes what's forgotten in the residencies do have a lot of clinical hours, but they also count the hours that they're on call, which means that sometimes the intern is in the intern sleeping room, sleeping, and I know that from working at a hospital.
Rarely from my own experience, but
Yeah, no,
it would have been nice to get some shut-eye. Didn't happen.
Well,
But
maybe it didn't happen. Yeah, and sometimes that didn't happen, but it did happen where I was practicing in hospitals. So,
all right, thank you.
Thank you, Mr. Chair, to inquire. Thank you, Mr. Chair. To go back to the malpractice, you said that malpractice rates did not go up for that advanced practice registered nurses in any of the states where they passed it?
not to my knowledge. Not to my knowledge.
Okay.
It has. I went online anticipating that question and tried to look that up last night. A lot of the studies that compared the states with collaborative practice to states without collaborative practice and their malpractice insurance rates seemed to stop about the time the pandemic hit. So, but the studies prior to that did not show any rate differential much at all. The rate differential comes in what kind of a nurse practitioner you are. If you're an acute care nurse practitioner, your rates might be higher. If you're a highly specialized dermatologic nurse practitioner, your rates might be higher. I'm a family nurse practitioner, so I know what the rates are for me.
Yeah, and there was a mention that Missouri is a more litigious state, so that might cause rates to go up. I did a search actually for litigious states, and I wonder if any of these places are in the list of places that have already expanded the scope of practice. California?
No, they have not.
They have not. New York?
They have.
They have. Georgia?
They have not.
It says the Philadelphia Court of Common Pleas and the Pennsylvania Supreme Court.
I don't believe, if Pennsylvania's, I don't think they have yet.
Okay. What about Illinois?
Illinois, you can transition into full practice in Illinois. And in Illinois, you have to spend so many hours in a collaborative, or so many hours or years in a collaborative practice prior to becoming full practice, but you can transition.
Okay, and the rates there have not gone up to your knowledge?
Not to my knowledge, no.
Okay, those were the top 5 listed, so thank you. Thank you, Mr. Chair.
Okay, so let's start with the malpractice question because I'm a little well. I want to thank everyone that's came by my office today. I've learned a lot, and it's been a great experience. And I'm now out of water in my office. If anybody didn't come by my office, you're welcome to come by later. So no, I had a great time. Thank you all. So the malpractice. So it's my understanding this law does not make nurses do a different job than they're doing now. So why would malpractice be a problem?
Exactly. We would be doing the same thing we're doing now. We just wouldn't have to have a mandated agreement from another profession to do it.
So just minus phone call, is that the Boggs way of putting it? Just minus the collaboration. So with the phone call, so we're and I'm trying to understand. So just I'm taking everything I've gleaned over the last couple weeks, and so with I believe to Keithley's question there, as far as the he almost answered it, but so let's just say I'm the doctor, you're the nurse, and I say you got to pay me $100,000. I love that idea, but you got to pay me $100,000 to give you permission to do what you do every day. But you've got to have a doctor's signature or whatever you call it. So I'm the collaborator. So you have to call me. You get permission from me, and that's going to cost you $100,000 more dollars as a practice. Let's say you have, a short amount of patients, and so let's just say that's $100 a patient. So you're not going to pay that. You're going to pass that on, correctly?
If so, I've not practiced, I have not owned my own clinic, but yes.
But I mean, as a business person, isn't that how it works as a business?
Yes, and so that increases healthcare
I mean, it makes
costs.
sense to me because if you're going to take that loss, then you've got to look at your end and see if that's going to work in your budget or not.
Exactly.
Or
and it will increase the cost of healthcare.
So me as a builder, whenever materials go up, the building costs more.
Yeah.
And the building we're talking about is the patient that comes through our doors and they leave with the care that they're looking for.
That's one factor in the increased costs.
Sorry, it's got to bring buildings into it too. Yeah. But I mean, everybody's heard everything from farming and everything else, but we're getting there. And I appreciate them bringing this forward because I've learned so much, and I can't believe that some of these things exist, but in a rural area, so I think I need to lay a foundation. First of all, I'm in a rural area. I have people leaving my area going to Joplin, Springfield because, there's better jobs, and I'm right in the middle of them. And it's not a huge deal because we can get there in 40 minutes, but we don't need to lose anything else. So a pullback, but for the malpractice side, if I understand it correctly, you're not getting permission to just do anything you want to do. You're going to do what you've done with permission.
Right. This bill would only give us permission to, to practice what we have been educated to do. Nothing past that.
So you know your limitations. You know what you're able to do. You know what you've been doing.
Right. And we refer to physicians all the time. I referred to cardiologists. I referred to dermatologists. I referred patients to. I referred to physicians all the time because I know when something is beyond my limit.
But if you're stumped, you know that you're going to reach out to some. You're not just going to go, let's see if, because it's a loved one's life. It may be my loved one, but you're not doing something other than what you normally do, and that was what I wanted to clarify. So, in my thinking, pardon me if I'm wrong, the malpractice is going to be the same as it is today. It might be in the hands of someone different. I don't know about that, but it shouldn't raise. I mean, maybe it will at the beginning whenever people's figuring out, but once you learn, you know your limitations. Mm-hmm. So, thank you very much. Thank you, Chairman. I believe that answered my question.
Other questions? I do have one quick one in relation to malpractice.
Yes.
What do you know what your limit is?
What my limit is?
What's your limit? Is it $1 million, $3 million? What's your limit?
I believe it's I believe it's a million per episode, up to 6 million per year.
And that would determine, the level you have, determine what the malpractice rate is.
Yes.
And the insurance
I could,
people.
if I wanted to go for a lower malpractice rate, I could.
You could go for a lower. Insurance people I talk to say that, hey, the reason your rate is lower because you're either working in a collaborative or you're working for a hospital. And if you take that away as an insurance, their risk-benefit ratio goes up and they would charge you a higher rate, and that most of the physicians are at a 3 million or higher rate. So when that happens, your insurance is going to go up to be at the same level of risk that he is. Does that make sense?
That makes sense, but so far we haven't seen it in any of the states with full practice authority.
All right. And again, my question is,
And a lot of those nurse practitioners are not practicing with the collaborative practice agreement.
and my question is, with St. Louis particularly, where it is, people try to get into St. Louis jurisdiction because of what lawsuits are scheduled and at what rate. That is a question I have, different than some of your others. I mean, I think we're known nationally for our settlements have been, that's the question. So,
That's
all
a
right.
Missouri problem.
And your testimony is, what percent of nurse practitioners' training is online?
Okay, the online component, because I taught both classroom and online. And I will tell you the difference. The difference was,
Can you give me a percentage?
no, because the didactic, the book learning part was online. And the clinical is done with preferably another APRN. Most schools require that most of their APRNs do clinical hours with another APRN, although they can do it with the physician if they can't find an APRN to do it with. So
How competitive is that?
how competitive is that?
Yeah, I mean, like competitive as compared to competitiveness for medical school, DO school. How competitive is that?
To find a collaborative practice?
No, how competitive is your studies? In other words, are you graded on the curve? Are you graded on performance? Does everybody pass? How competitive is that?
We are, at the school where I taught, we were graded on a strict A, B, C, D scale. If you made a C in a clinical course, you had to repeat it. If you made a C more than once in a clinical course, you were gone.
Okay, that was answering my question. All right. Other questions? If not, thank you very much.